Hello, let's learn about a practical guide to implementation of antimicrobial stewardship in hospitals. Why to implement stewardship in hospitals? We'll learn about the antimicrobial utilization, how to combat resistance, what do we understand by stewardship, what are the goals of stewardship, and how to implement stewardship. Misuse and overuse of antibiotics is a pressing concern. The last 50 years have witnessed the golden age of antibiotics, but recently in the last 2 decades we have seen a misuse and overuse of antimicrobial consumption, which is largely as a result of uncontrolled prescription or over the counter. As you can see from this map, which the red ones are the areas or the countries or the places where the misuse or the percentage change in the antibiotic consumption has increased tremendously. Most antibiotics are given to animals, and most of them are healthy. If you see the bluer areas, it's like the 70% of the antibiotics in US are given for non-therapeutic indications in animals, while the darker blue is for the animal therapeutic. Greeners are for the human therapeutic, and orange is for the other areas such as pesticides and insecticides. More recent global data on the antibiotic prescription undertaken using a global prevalence study has revealed significant variation in the practice against commonly used metrics of the quality of prescription. If you refer to the 30% rule, 30% of all the hospital inpatients at any given time receive antibiotics. Over 30% of the antibiotics are prescribed inappropriately in the community. Up to 30% of all surgical prophylaxis is inappropriate. 30% of all hospital pharmacy costs are due to antimicrobial usage. 30% of all pharmacy costs can be saved by stewardship program. The rising threat of antimicrobial resistance has been identified as a major threat by WHO. And in 2015, WHO has set up the global action for antimicrobial. There are numerous drivers for antimicrobial resistance. Human misuse and overuse is a key driving factor. And the three-pillar approach is recommended, such as optimizing the use of antimicrobials, preventing the transmission of drugs and organisms, and improve the environmental decontamination. If you see the mechanism of drivers antimicrobial, it is the human antimicrobial misuse, then it's the animal antimicrobial misuse, then environmental contamination, and then the healthcare transmission as the major drivers of to achieve the approach against antimicrobial resistance, integrated approach is required, such as antimicrobial stewardship, diagnostic stewardship, and infection control. Stewardship is an organization or hospital-wide approach to promote and monitor judicious use of antimicrobials to produce their future effectiveness. And it can be at the individual or a team level. It is an interprofessional effort across the continuum of care. It involves timely and optimal selection for the best clinical outcome for the treatment or prevention of infection with minimal toxicity to patients and minimal impact on resistance and other adverse events such as clostridium. The goal is to improve the infection cure rates, reduce the surgical infection rates, reduce morbidity and mortality. The prevention of surgical site infection remains one of the major doable areas of stewardship programs. And the impact of stewardship program on surgical site infection is evident from the study that there has been a significant reduction in the surgical site infection rates program. Similarly, we have a number of studies where we have been observed that stewardship program has optimized the patients. It has helped in reducing the duration of the hospital stay. It has helped in reducing the cost in colonization or infection by the controlled use of implementation of infection control measures. Antibiotic optimization intervention has helped in the leading to sustained reduction in caution deficit infection rates. Restricting the relevant agents can reduce the colonization or infection with gram-positive or gram-negative resistant bacteria. Controlling the healthcare costs without adversely impacting quality of the care is one of the goals of the stewardship program. AMS tests undertaken by nurses ensure that the adequate doses of antimicrobials are given according to patient characteristics. Remind the treater prescriber to review the need for antimicrobials on day 3 and day 7. Ensure the suitable implementation of protocols for antimicrobial treatments. Teach about the appropriate use of antimicrobials. Teach about the infection prevention control. Are the AMS tests undertaken by nurses? How to implement the stewardship program? The strategies include top-down approach or a bottom-up approach, push, pull, and carrot or stick tactics, and typically involve packaged approaches. They also include methods for providing trainer and decision support, interventions such as specific toolkit, checklist, and algorithms. The core elements of this antimicrobial stewardship program include leadership support, accountability, expertise on infection management, education, other actions aiming at improving antimicrobial usage, monitoring surveillance, and reporting and feedback. The 8 key steps for implementing stewardship program include assess the motivation, ensure accountability, set up the structure, define the priorities, identify the effective interventions, identify the key measurements, educate and train, and communicate. How to assess the motivations, analyze the situation, do a SWOT analysis, define where you are, where you want to go, what can be implemented. For example, simple algorithm, prescribing guidance, IV to owner conversions, the provision of microbial support, and others. Accountability. The program should be supported by senior leadership or management. A team of people and resources should be allocated by the head of organization to implement a program. Secondary drivers such as promoting cultures of optimal antibiotic usage in the facility, engage the administrative clinical leadership to champion the social effort, and specific change ideas such as identify the clinical providers, work with the administrators, engage physician champions, bring the disciplines together, consider having multidisciplinary group can help in the stewardship program. Set up the structure and organization, dedicated resources. A multidisciplinary team is required with such as ID physician and microbiologist, a pharmacist, specialist nurses in the committee. Governance within the hospital's quality improvement and patient safety governance structures also play a key role. There should be clear lines of accountability between the chief executive, the clinical governance, drug and therapeutic committee, and infection control committee, and the stewardship committee. Models of antimicrobial prescription pathway is depicted from this slide. The medical director and the CEO and the infection control manager from the top level helps in assisting the antimicrobial stewardship team through patient safety committee, the clinical governance committee, infection control committee, drug and therapeutic committee, ward-based clinical pharmacy, the prescribers, and the microbials and ID physicians. The objects of the stewardship program and how they are going to be achieved and measured needs to be agreed by all the stakeholders. One way of doing this is to have a driver diagram, such as having a goal or vision, high-level factors, and specific projects. Driver diagrams can help the stewardship team to explore the factors, show how the factors are connected, and act as a communication. This is the example of a driver diagram. We can have a goal, the primary drivers, and the secondary drivers for an industry. Effective interventions for the settings such as core strategies and supplementary strategies. Core strategies which include formulary restrictions, prospective audits, and multidisciplinary team. And similarly, supplementary strategies like dose optimization, education, order form, and the combination of the therapies. Core strategies have evolved such as front-end strategies such as pre-authorization and restriction, and back-end strategies such as prospective audit and feedback. Each has their own advantages and disadvantages. Like pre-authorization has prevent unnecessary or inappropriate initiation of antibiotics, ensures optimal therapy. However, disadvantage is that it's a little effect on empirical therapy, loss of prescriber autonomy, and may delay the therapy. The stewardship goal is to have a right drug, right dose, right time, right duration, and for every patient. So do not start the antibiotics in absence of clinical evidence of factor of the infection. Take history, evaluate signs and symptoms, include review, stop date of duration, and ensure relevant microbial specimen taken. We can have the golden rules of antimicrobial prescribing in a mnemonic called as Mind Me, where M stands for microbiology guides, then I for indications should be evidence based, N for narrow spectrum required, D for dosage appropriate, M for again minimize duration therapy, and E for ensuring monotherapy. There should be clear clinical guidelines or care pathways into the system. Formal restriction or approach system should be considered in the implementation. Back-end strategies include prospective audits and feedback. Commonly used are review of the indications, review of the appropriateness, review of the directed therapy. Audits and feedback should be managed by the medical infection specialist or specialist pharmacist. And during the review, a range of point of care stewardship interventions are useful to provide directly and timely feedback to the prescribers. So this is how the diagnostics play a key role in the antibiotic stewardship program. While diagnostic stewardship ensures that there is a right test for the right patient at the right time, stewardship aims to have a right interpretation for the right microbial at the right time. That play a key role in antimicrobial stewardship program. They help in collaborating the healthcare workers on microbiology issues that impact treatment and antimicrobial resistance. They provide comments in collaboration with the stewardship team to guide the therapy, and they participate in the national surveillance system. Rapid diagnosis test again has a key role in optimizing treatment. The role that rapid diagnosis play is the most appropriate in the fight against AMR. They help in the empirical diagnosis. Traditional diagnosis test where we can be delayed, so treatment may fail. So the empirical diagnosis can do well taken at the right time by help of rapid diagnostic test. If you cannot measure it, you cannot improve it. And as rightly said, identify the key measurements. A measurement of performance is essential to evaluate the impact of the stewardship interventions. The surveillance of the antimicrobial usage, data collection for quality improvement, and analysis of the hospital data sets can be done as a key measurement. Nutrients is imperative. Adapt the empirical treatment according to local guidelines. Demonstrate the changes. Identify the wards with highest usage of antimicrobials and have current preventive measures for this. Have prescription surveillance through point prevalence surveys. Of this matters such a difference in the quality of prescription between antibacterials and antifungals needs to be analyzed with the clinical stakeholders. Antimicrobial usage at the individual patient level using an electronic prescribing system to the hospital information system is key. Data from the hospital pharmacy computer system showing antimicrobial usage and data should be analyzed in terms of defined daily doses across both the OPD settings and inpatient settings and across high risk. The slide shows how the antimicrobial consumption could be analyzed from, say, from beta-lactam, from quinoline, from anti-clostridium agents and other antibiotics. This data needs to be analyzed at regular intervals, antibiotic-wise, departmental-wise, and patient-wise. Then we have an antibiogram where is a accessible pattern of the different antimicrobials against different organisms that needs to be collected and clinicians for treatment guidance. Then we have structural indicators, process indicators, outcome indicators, and balance measures. Structural indicators include availability of team, availability guidelines. Process measures include compliance towards the antibiotic guidelines, towards antimicrobial consumption, compliance towards interventions such as de-escalation, rational surgical prophylaxis, compliance with the care bundles, and others. Outcome measures include the rate of infections, rate of resistance, and the balancing measures include this mortality, readmission, admissions, and others. So, a common quality improvement methodology is a plan to study act is helpful in this fight against antimicrobial resistance in antimicrobial stewardship program. The linkage of the hospital data sets such as hospital admissions, lab data, and patient outcomes allows measurement of the impact of the stewardship interventions. Now, eyes can see what the mind doesn't know. So, education is a very key component of any stewardship program. It should include all the healthcare professionals as well as patients and educating patients and the general public about hygiene and antibiotic use is very important and may indirectly support the hospital education. Communication is another key component of the success of the AMS program. Communicate to the clinical stakeholders, to the prescribers, and to the public, and about the stewardship, antimicrobial stewardship interventions, and the success and the achievement. 10 key points for the appropriateness of antibiotics in hospital patients include: get microbiology samples as required, when to treat the bacterial infections, when indicated start empirical treatment, prescribe the drugs at optimal dosage, use antibiotic combinations only when evidence suggests, avoid antibiotics with higher likelihood of developing resistance, remove all the invisible ineffective devices, always try to de-escalate from broad to narrow or IV to oral, and stop antibiotics when not required, and set up local teams in multidisciplinary teams for in the committee of antimicrobial stewardship. Specific situation where antibiotics should be withheld should be defined for all the syndromes. Infections for which short course therapy has been shown to be equivalent in efficacy to longer therapy should be. A number of interventions are key to success of a stewardship program, such as establishing clear aims or visions of stewardship, have management support, multidisciplinary team, effective communications, evidence-based stewardship interventions, education, and ensure early or short-term. Thanks.